Welcome back to the Deep Dive. Today we are doing a real masterclass on, well, one of the most complex and frankly challenging areas in medicine, the entire small bowel.
It really is. It's this crossroads of surgery, pathology, medicine, radiology, and the problem is when you're studying for exams, everything gets stuck in its own lane.
Exactly. And our mission today is to tear down those walls. We're aiming for a single integrated discussion, really tailored for those of you facing those big exams, PG, MCH, NEET, you name it.
Right, we're connecting the dots as the difference between just passing and truly excelling.
And the quality of the information we're working with today is just top tier.
It is. The core of this deep dive is built on material that was put together by Dr. Senthil Kumaran. He's an associate professor at AIIMS Nagpur.
And his background is pretty incredible.
Yeah, absolutely. He's an alumnus of GPMR Pondicherry and PGMR Chandigarh, two of the most prestigious institutions in India. So we're talking about someone who is not only a fantastic teacher and surgeon researcher, but someone who has been through this exact high-stakes exam process.
So he knows exactly what you need to know and what you can maybe leave behind.
Precisely. The information is filtered, it's refined, it's high yield. We're going to cover everything from celiac and Crohn's to obstruction, volvulus, short bowel syndrome, all in one place.
The goal is total recall. We want you to see a biopsy finding and instantly know the surgical plan.
Yeah, we want to cut down that, what they call cognitive switching cost. You shouldn't have to pause during an exam and think, okay, the pathologist calls it this, but what does the surgeon do? We're fusing those answers.
Okay, let's unpack this. We'll start where a lot of these concerns begin, in primary care. Let's get into section 1, the malabsorption master block triads and buzzwords.
A great place to start. And you really have to begin with celiac disease.
Right, so celiac disease, it's an immune response to gluten. Clinically, what's the classic picture? What's the red flag?
The absolute classic triad, the one you have to know, is steatorrhea.
So that's the pale, bulky, foul-smelling stools that float.
Exactly. Then you have significant bloating or abdominal pain and, of course, persistent diarrhea. And the key is that it's all triggered or made worse after eating gluten.
But, it's not always that clean, is it?
Not at all. And this is a huge clinical point. The majority of patients might actually present atypically. You should be thinking about celiac with unexplained iron deficiency anemia, or maybe early onset osteoporosis, dental enamel defects, even weird neurological symptoms.
So the absence of diarrhea doesn't rule it out.
Absolutely not. That's a critical takeaway.
Okay, so you have that clinical suspicion. You need a test. What's the first line go-to diagnostic?
That's going to be the anti-TTG IgA, the anti-tissue transglutaminase IgA antibody. It's a fantastic test, very sensitive and specific.
But there's a catch, isn't there? Exam writers love this one.
They do. The catch is IgA deficiency. Patients with celiac have a higher rate of being IgA deficient in general. So if you only check the anti-TTG IgA, you could get a false negative.
So what's the workaround? How do you avoid that trap?
The proper way is to check a total serum IgA level at the same time. If that total IgA is low, you know the TTG IgA test is useless.
And then what?
Then you pivot. You test for the deaminated gliadin peptide IgG, the DGP IgG, or an anti-TTG IgG. That ensures you're not missing the diagnosis just because of the patient's underlying IgA status. That is a very high-yield point.
Okay, so serology is positive. The gold standard is still the biopsy, right?
Yeah.
Let's get into the pathology. What are the 3 key things a pathologist is looking for?
The 3 non-negotiables are, first, villus atrophy. The little finger-like villi that absorb nutrients are blunted or completely flattened.
Huge loss of surface area.
A massive loss. Second is crypt hyperplasia. The bases of the glands, the crypts, get really long and overworked trying to regenerate the damaged lining.
And the third?
A big increase in intraepithelial lymphocytes, or IELs. These are the T cells that have moved into the epithelial layer to attack. It's the sign of the ongoing immune assault.
And pathologists have a way of grading this, don't they?
They do. It's the Marsh classification. It goes from Marsh 1 up to Marsh 3C, where Marsh 3 is that total villus atrophy, the most severe form.
And this all comes down to genetics, doesn't it? The HLA association.
It does. Over 90% of patients with celiac have either the HLA-DQ2 or HLA-DQ8 haplotype. These genes are just incredibly good at presenting the gluten peptide to T cells, and that's what kicks off the whole inflammatory cascade.
So it's a T cell-mediated type IV hypersensitivity.
Exactly. It's a slow, chronic, cell-mediated destruction.
Okay, last point on celiac, and it's the deadliest one, the complication everyone has to remember.
Enteropathy-associated T cell lymphoma. EATL
A
lymphoma.
very aggressive cancer.
Extremely aggressive. It's a non-Hodgkin T-cell lymphoma that grows right out of that chronically inflamed small bowel. It's the ultimate reason why a strict, lifelong gluten-free diet isn't just for comfort, it's a life-saving intervention.
Perfect. That's a great transition. So if celiac is autoimmune, let's look at two conditions that can mimic it but have an infectious cause: tropical sprue and Whipple disease.
Great comparison.
Let's start with tropical sprue. How does the patient history immediately point you in that direction?
With tropical sprue, the history is all about geography. You are looking for someone who has lived in or recently traveled to a tropical area like South Asia, Southeast Asia, the Caribbean.
And the onset is different from, say, simple traveler's diarrhea.
Very different. The symptoms can be insidious. They might not even start for months or years after they've returned.
So what's the single best way to tell it, apart from celiac, therapeutically?
It's the response to antibiotics. Unlike celiac, tropical sprue is thought to be from some kind of chronic bacterial overgrowth or post-infectious state, and it responds beautifully to a course of tetracycline.
And the vitamin deficiencies are a bit different too, right?
Yes. Celiac usually causes an isolated folate deficiency. Sprue, because it can affect the whole small bowel, often causes deficiencies in both folate and vitamin B12. So if your patient gets better on tetracycline, it's sprue, not celiac.
Okay, now for Whipple disease. This one is fascinating. It's a systemic infection. Why does it so often get misdiagnosed as something like rheumatoid arthritis at first?
Because the gut symptoms can be the last thing to show up. The classic triad starts with arthralgias, joint pain that moves around, and then you get CNS symptoms like confusion or eye movement problems. The malabsorption can come years later.
So it's a true multi-system disease.
Absolutely. It affects the joints, the brain, the heart, the lymphatics. The gut is just one piece of the puzzle.
Pathologically, what's the one buzzword, the one finding on biopsy that confirms Whipple disease?
You have to find the PAS-positive foamy macrophages in the lamina propria.
Break that down. PAS positive.
PAS is the stain they use,
Ah.
periodic acid shift, and the macrophages look foamy because they are stuffed full of the bacteria, Tropharema whippuli. Seeing those is completely pathognomonic.
And because it's a systemic bacterial infection that can get into the brain, the treatment has to be pretty aggressive.
Extremely. You have to use antibiotics that can cross the blood-brain barrier, so it's usually 2 weeks of an IV antibiotic like ceftriaxone to start.
And that.
Then a very long course of oral antibiotics, typically TMP, SMX, for at least a year, sometimes 2. You have to eradicate it completely to prevent a fatal neurological relapse.
Okay, great summary. Let's quickly touch on two other causes, one congenital, one parasitic. Microvillus inclusion disease, what's the story there?
This is a truly devastating congenital condition. The microvilli, the tiny little brushes on the cells that do the final absorption, just don't form correctly.
So the presentation would be immediate.
Day 1 of life. A newborn, which is massive, profuse, watery diarrhea. They have virtually no absorptive surface. They require lifelong TPN and often, eventually, a small bowel transplant.
And finally, let's differentiate two common parasites.
Yeah.
Giardia and Cryptosporidium.
The easy way to remember is mechanism and host. Giardia causes malabsorption by just coating the inside of the bowel. It's strictly non-invasive.
But Cryptosporidium is different.
Completely different. Cryptosporidium is an intracellular parasite. The key things to remember are that you use an acid-fast stain to find it in the stool, and if you see it causing severe diarrhea, you have to be thinking about an immunocompromised patient.
Like someone with advanced HIV/AIDS.
Exactly. That's its classic association.
Okay, that wraps up a really comprehensive look at the malabsorption block. Let's pivot now to the inflammatory conditions. Section 2, Crohn's versus UC, specifically from the small bowel angle.
Right. And for anyone going into surgery, understanding the pathology here is everything. It dictates the entire course of the disease and what you do about it.
So let's start with Crohn's. You've called it the transmural terror. Why that name?
Because transmural means the inflammation goes through all the layers of the bowel wall, the mucosa, submucosa, the muscle layer, all the way out to the serosa.
And why is that so important surgically? What does that lead to?
Well, because it goes through the whole wall, you get deep scarring that causes narrowing or strictures. And it allows these tracts to form, which become fistulous tunnels from the bowel to other organs or the skin.
So it's a penetrating and obstructing disease.
Precisely. And that's why it needs surgery so much more often than you see.
Okay, so beyond being transmural, what are the other two classic pathological features of Crohn's?
The pattern of involvement is what we call skip lesions. You'll have a segment of really inflamed bowel, and then right next to it, a segment of perfectly normal bowel. It's discontinuous.
And under the microscope.
The classic finding is non-caseating granulomas. You have to remember that. It's not in every single biopsy, but if you find one, it's pathognomonic for Crohn's.
I've heard surgeons talk about creeping fat when they're operating. What is that?
That's a great visual. The mesenteric fat actually wraps itself around the inflamed part of the bowel, almost like it's trying to protect it or wall it off. It's a dead giveaway in the operating room.
And on imaging, what's the classic sign of severe Crohn's in the terminal ileum?
On a barium study, it's the string sign. The bowel is so narrowed by the scarring and swelling that only a thin little string of barium can get through.
Crohn's loves the terminal ileum.
Mm.
This has consequences beyond just inflammation, right? We're talking B12 deficiency, but also kidney stones. How does that happen?
This is a perfect example of integrated physiology. The terminal ileum is where you absorb bile salts and where fat absorption is finalized. When it's diseased, you get a lot of unabsorbed fat passing into the colon.
Okay.
Now, normally, calcium in your diet binds to oxalate in your gut and you just excrete it. But when there's all this extra fat in the colon, the calcium binds to the fat instead.
So that leaves the oxalate all by itself.
Exactly. The oxalate is left free and it gets absorbed into the bloodstream in huge amounts. That leads to hyperoxaluria, which directly causes calcium oxalate kidney stones. It's a classic high-yield connection between GI pathology and urology.
That is a fantastic explanation. So let's contrast all of that with ulcerative colitis. If Crohn's is skip lesions and transmural, what is UC?
UC is the exact opposite. It's continuous and it's superficial or mucosal. It always starts in the rectum and just spreads upwards in one continuous sheet of inflammation.
And it basically spares the small bowel.
It spares the small bowel,
Yeah.
with one very specific exception you need to know about.
And what's that exception?
It's called backwash ileitis. If you have really severe colitis that goes all the way up to the ileocecal valve, the inflammation can kind of splash back a few centimeters into the terminal ileum.
But it's not the same as Crohn's ileitis.
Not at all. It's still just superficial mucosal inflammation. You don't get the deep ulcers, you don't get the granulomas, and it's contiguous with the colon inflammation. It's a secondary effect.
And the really big, scary surgical emergency that's almost exclusively associated with UC.
Toxic megacolon. This is when the colon rapidly dilates, becomes non-functional, and is at huge risk of perforating.
And why does that happen in UC?
Because the inflammation is so severe in the mucosa, it releases inflammatory mediators that basically paralyze the deep muscle layers. The colon just blows up like a balloon. It's a true surgical emergency.
So to sum it up for a student, Crohn's is deep, so it causes strictures and fistulas. UC is superficial, so its big complications are toxic megacolon or cancer.
That's the perfect way to think about it. The pathology dictates the complication. You resect a Crohn's stricture, you often have to remove the entire colon for severe UC.
The logic is crystal clear. Okay, let's move on to an acute surgical crisis. Section 3, Obstruction Essentials. We're focusing on small bowel obstruction, or SBO.
SBO, probably the single most common reason for an emergency surgical consult in the world. You have to know this inside and out.
We have the 4 cardinal signs: colicky pain, vomiting, distension, and constipation. Why is the pain colicky? What's happening?
The colicky pain is the bowel trying to fight. The segment just before the blockage goes into these violent waves of peristalsis to try and push the contents through. That spasm is the pain.
And the other signs just follow from that?
Exactly. Vomiting because nothing can go down, distension as gas and fluid back up, and constipation because nothing is getting through.
And let's repeat, the single most important cause of SBO in the developed world.
Postoperative adhesions, period. If a patient has a scar on their abdomen and they present with an SBO, it's adhesions until proven otherwise. It accounts for something like 75% of cases.
So the patient comes into the ER. First step is usually an X-ray. How do you confidently tell an SBO from a large bowel obstruction, an LBO, on that film?
Location and morphology. With SBO, the dilated loops of bowel are usually in the center of the abdomen, and the folds you see, the valvulae conventus, go all the way across the width of the bowel.
And you get that classic pattern.
You can, yeah. The stepladder pattern, which is just these multiple air fluid levels stacked on top of each other on an upright film.
And how is LBO different?
LBO loops are peripheral, kind of framing the abdomen. And the folds, the haustra, do not go all the way across. It gives it a more segmented, lumpy look.
Okay, so you've diagnosed an adhesive SBO. For a stable patient, there's a conservative management triad. What is it?
The triad is drip and suck. So first, IV fluids. These patients are incredibly dehydrated,
Drip.
right? And second, NG tube decompression. That's the suck. It rests the bowel and stops them from vomiting. And third, you have to be aggressive with correcting their electrolytes.
And then you wait. How long?
The standard is to observe for 48 to 72 hours. The data shows that if an adhesive SBO is going to resolve on its own, it usually does so in that window.
That seems like a long time to wait if you're worried about the bowel dying. Is there anything you can do to speed up that decision?
That's a great point. And yes, there is. The most useful tool we have now is the gastrographin challenge. You have the patient drink this water-soluble contrast.
And what are you looking for?
You're looking to see if that contrast makes it into the colon on an X-ray taken at 24 hours. If it does, the chance of the obstruction resolving without surgery is over 90%. If it doesn't, they're probably going to the OR.
So when do you skip all of that and go straight to surgery?
Yeah.
What are the absolute red flags for strangulation?
Okay, there are a few. First, the pain changes. It goes from colicky to constant and severe. Second, signs of systemic toxicity fever, high heart rate, high white count.
Signs of peritonitis?
Yes. Rebound tenderness, guarding. That means the bowel might have perforated or is dying. And finally, if a CT scan shows a closed-loop obstruction, which is a surgical emergency, any of those, and you're going straight to the operating room.
Great. Let's shift gears into Section 4. High-yield surgical entities. This is where we hit the classic mnemonics and signs. Let's start with Meckel's diverticulum.
Ah, Meckel's. The classic. It's the most common congenital anomaly of the GI tract, and it's famous for its mnemonic.
The rule of twos. Let's break it down.
Okay. It occurs in 2% of the population. It's found about 2 feet from the ileocecal valve. It's usually about 2 inches long.
And it contains two types of something.
It can contain 2 types of ectopic mucosa, most commonly gastric, but sometimes pancreatic, and it usually presents before the age of 2.
And it's more common in males, right? The 2.1 ratio.
That's the last one, 2.1 male to female.
The really important point is that ectopic tissue. Why does the gastric mucosa cause the classic presentation of painless bleeding?
Because that ectopic gastric tissue has parietal cells and it secretes acid. That acid burns an ulcer into the normal unprotected ileal mucosa next to it, and that ulcer bleeds.
Often massively.
Yes, but painlessly, which is why it can be so confusing, especially in a little kid.
And how do you diagnose it?
With a technetium 99-meter Pertechnetet scan or a Meckel's scan, the radioisotope gets taken up by the gastric mucosa, so it lights up on the scan.
And what's the rule for treatment? Do you always take it out?
No. The rule is you only treat it if it's symptomatic, if it's bleeding, causing an obstruction, or inflamed. If you find one by accident during another surgery, you generally leave it alone in an adult.
Okay, let's move to volvulus, the bowel twisting on itself. Sigmoid versus cecal. Let's start with sigmoid.
Sigmoid volvulus is much more common. You typically see it in elderly, often bedbound patients with chronic constipation. They get this huge, redundant sigmoid colon that's prone to twisting.
And the X-ray sign is iconic.
It's the coffee bean sign. It's this massive dilated loop of colon that looks exactly like a giant coffee bean.
Now contrast that with a cecal volvulus.
Sepal volvulus is different. It tends to happen in younger patients, and it's because the cecum isn't properly fixed down, so it's hypermobile. On a CT scan, the buzzword is the whirl sign, where you can see the twisted mesentery.
And the treatment is very different and non-negotiable.
It is. For a cecal volvulus, the treatment is a right hemicolectomy. You have to take it out.
Let's move to the pediatric high-yield cases. Jejunal atresia.
This is a newborn who presents with bilious vomiting right after birth. It's a congenital blockage.
And the X-ray sign.
The classic triple bubble sign. You see air trapped in the stomach, the duodenum, and the blocked, dilated proximal jejunum. It's a surgical problem that needs resection and anastomosis.
Next up, intussusception. One part of the bowel telescoping into another.
Yes. The classic triad in a child is severe, intermittent abdominal pain, a sausage-shaped mass you can feel, and the very high-yield red currant jelly stools.
Which is what exactly?
It's a mix of blood and mucus from the ischemic inner loop of bowel.
Diagnosis with ultrasound, which shows the target sign. But the management is critically different between kids and adults.
This is a huge point. In kids, it's usually idiopathic, and you try to fix it non-operatively with an air or contrast enema.
But in adults?
In adults, you have to assume there is an underlying lead point, like a tumor. So adult intussusception always goes to surgery for resection. You never try an enema.
Got it. Meconium ileus. This brings us back to cystic fibrosis.
Right. Newborn with CF has this incredibly thick, sticky first stool, the meconium, that causes a blockage. The unique X-ray finding is the soap bubble appearance in the right lower quadrant. It's a classic sign of CF.
Okay, last two in this section. SMA syndrome. Who gets this?
This is a syndrome you see in very thin patients or people who've lost a lot of weight very quickly. The fat pad between the aorta and the superior mesenteric artery disappears.
And the SMA then compresses the duodenum.
Exactly. It just pinches it shut. Treatment is trying to get them to gain weight back. If that fails, surgery to bypass the blockage, a duodenogenostomy.
And finally, the most urgent one, mesenteric ischemia. What's the phrase that should set off alarm bells?
Pain out of proportion to abdominal findings. The patient is writhing in agony, but their belly is soft when you examine it. That discrepancy means visceral pain from ischemia.
And this requires immediate action.
Absolutely. This is a vascular emergency. It needs angiography and either revascularization or an embolectomy. Time is Bowel.
That's a powerful summary. Let's move into our fifth section, benign conditions and long-term management, starting with short bowel syndrome.
SBS is what happens after a massive small bowel resection. The formal definition is having less than 200 centimeters of small intestine left.
And what's the most common reason someone would need that much bowel removed?
That massive mesenteric ischemia we just talked about, usually from an SMA embolism.
And the consequences are obviously severe.
Profound malabsorption and incredibly rapid transit time. It's a huge challenge to manage. The key thing to remember is that losing the ileum is much, much worse than losing the jejunum, because the ileum is where you absorb B12 and bile salts.
Management used to be just TPN, but things have evolved, right?
They have. While TPN is life-saving, the goal is to promote intestinal adaptation to make the remaining bowel work better. The big breakthrough has been GLP-2 analogs.
And what do?
They're hormones that stimulate the growth of the intestinal lining and slow down transit, basically making the short piece of bowel you have left more efficient. It can help get patients off TPN.
Let's talk about stomas. Specifically in ileostomy, what are the main concerns compared to a colostomy?
An ileostomy has very high output, it's very liquid, and it's full of digestive enzymes. So the main concerns are dehydration and huge electrolyte losses, especially sodium.
And complications. What's the most common long-term problem and what's the scariest early one?
The most common long-term problem is skin excoriation around the stoma from that caustic output. But the earliest, most dangerous one is stoma necrosis. If the stoma turns dark or black in the first 24 hours, it means it's lost its blood supply and you have to go back to the operating room immediately.
Okay, let's go back to infections. Intestinal TB versus typhoid. They both like the terminal ileum. How do you tell their ulcers apart?
This is a classic exam question. It's all about the orientation. TB ulcers follow the lymphatics, which run around the bowel, so the ulcers are transverse. This leads to fibrotic strictures.
On typhoid.
Typhoid ulcers target the Peyer's patches, which are oriented along the bowel. So typhoid ulcers are longitudinal. They are more famous for causing hemorrhage and perforation.
Transverse for TB, longitudinal for typhoid. Got it. Last topic here, fecal fistulas. How do you classify them?
By output. A high output fistula, which is more than 500 millilevers a day, is much more serious. It just drains the patient of all their fluid and nutrition.
And the management follows a famous protocol, the 4 S's.
That's right. You have to stabilize the patient before you can even think about definitive surgery. So first, sepsis control. Drain any abscess.
Okay.
Support, meaning nutrition, almost always TPN. Third is skin care, protecting the abdomen. And the last S is surgery, but it's critically delayed surgery.
Right, delayed.
Because you cannot operate successfully on an infected, malnourished patient with inflamed tissues. You have to wait weeks or months for everything to calm down and for the patient to get strong. Rushing to operate is a recipe for disaster.
That makes perfect sense. We have covered a huge amount of ground. Let's distill it all down now in section 6. Super high yield exam pearls. The final consolidation.
All right, the rapid fire round. Let's do it.
Pearl number 1. Best initial test for celiac disease.
Anti-TTG IgA.
Number 2. The most severe complication of celiac.
EATL lymphoma.
Number 3. What cures tropical sprue?
Tetracycline.
Number 4. The pathognomonic finding in Whipple disease.
PAS-positive foamy macrophages.
5. 3 key features of Crohn's.
Granulomas, skip lesions, transmural inflammation.
6. 2 key features of UC.
Continuous and mucosal.
7. Most common cause of SBO.
Adhesions.
8. Most common cause of LBO.
Malignancy.
9. Sign for sigmoid volvulus.
Coffee bean sign.
10. Treatment for cecal volvulus.
Right, hemicolectomy. 11. Sign for intussusception on ultrasound.
The target sign.
12.
Mnemonic for Meckel's.
The rule of twos. 13. What causes bleeding in Meckel's?
Ectopic gastric mucosa. 14. What causes SMA syndrome?
Loss of the mesenteric fat pad, compressing the duodenum. 15. The classic pain description in mesenteric ischemia.
Pain out of proportion to findings. 16. The definition of short bowel syndrome.
Less than 200 centimeters of small bowel.
17. The direction of a TB ulcer.
Transverse.
18. The direction of a typhoid ulcer.
Longitudinal.
Number 19. The cause of red currant jelly stools.
Ischemic. Slough mucosa. And finally, number 20, the key drug for managing short bowel syndrome long-term.
GLP-2 analogs. Wow. That is an incredible consolidation. We've built this entire integrated framework on the foundation Dr. Senthil Kumaran provided. So what does this all mean for you, the listener, when you're in a clinical crisis?
It means speed and clarity. When you see an adult with intussusception, you don't even think about an enema. You know there's a lead point, you think cancer, and you go to the OR. When you see a fistula, you know the priority is not surgery, it's sepsis and nutrition. It turns a list of facts into a decision-making algorithm.
For our final provocative thought, let's go back to volvulus. We distinguish between sigmoid and cecal. I want you to really think about why the surgical treatment is so radically different.
This is a perfect example of anatomy dictating everything we do. The sigmoid colon has a long, floppy mesentery. When it twists, you can often untwist it with a scope because the blood supply has a chance to recover.
But not the cecum.
Not the cecum. The cecum has a much more tenuous blood supply. When it twists, that whorl sign on the CT, the ileocolic artery is almost always compromised beyond repair. The risk of necrosis is just too high to do anything other than an immediate resection.
So it's all about the blood supply.
It all comes down to the blood supply. And understanding that difference is the difference between saving bowel and, well, having to remove it. It explains everything about why we make those different choices.
A profound point to end on. Thank you for diving so deep with us today.
Keep rising, doctors.